My name is Dr. Adam Slivka. I'm at the University of Pittsburgh Medical Center, and I'm going to be discussing our study that is just published in Gastrointestinal Endoscopy entitled The Single-Use Duodenoscope for Endoscopic Retrograde Cholangiopancreatography performed by endoscopists with a wide range of experience. This was an international multi-center study performed out of the University of Pittsburgh, Virginia Mason Medical Center in Seattle, Hofstra Northwell in New York, Mayo Clinic in Rochester, the Erasmus Medical Center in Rotterdam, Beth Israel Deaconess in Boston, and the University of California, Los Angeles campus, and was funded by the Boston Scientific Corporation. As a disclosure, I'm a PI for IRB approved research funded by Olympus and Boston Scientific. In terms of introduction, outbreaks of duodenoscope associated multi-drug resistant organisms associated with patient-to-patient cross-contamination have been documented internationally. They're receiving a lot of attention in our journals and in the lay press. To help mitigate vertical transmission of these infections, the United States Food and Drug Administration cleared the first single-use duodenoscope for marketing back in December of 2019, and they also anointed it with breakthrough technology status. We previously reported a case series of 60 ERCPs showing good efficacy and safety using a single-use duodenoscope by expert endoscopists. The aim of the current study was to assess the clinical use of this single-use duodenoscope by endoscopists with varying level of experience. And this study was really prompted by commentary by the FDA and by people in the endoscopic communities that said, well, experts can use it, what about other people? So to that end, we used the EXALT Model D duodenoscope. We got IRB approval at the 7 academic medical centers mentioned, and we had 14 highly experienced endoscopists, and we arbitrarily define that as lifetime ERCPs greater than 2,000, and 5 less experienced endoscopists at these institutions, that being lifetime ERCPs less than 2,000. And we enrolled consecutive adults 18 and older without altered pancreaticobiliary anatomy who were already scheduled for ERCPs. The recruitment for this study took place in phases as disrupted by COVID between January and February of 2020, and then a pause, and then we picked up again between May and July of 2020, and finally finished off in September to February of 2021, and enrolled 100 patients. The endpoints in this study were compared by endoscopist level of experience and included the completion rate, the crossover rate from a single use to a reusable duodenoscope, the satisfaction based on a subjective rating of 1 to 10, 10 being best, ERCP related adverse events reported by 7 days, the number of cannulation attempts, and we also looked at the ASGE grade of procedural complexity. 283 consecutive patients were screened, 200 patients participated, and we had complete follow-up at 189 of the required 7-day follow-up. Of the 200 ERCPs, there was a crossover rate of 9.5%. 7 cases couldn't be completed. 3 were in the crossover group. 2 were changed to EUS guided procedures, and 2 of the ERCPs were aborted. 50 of the procedures were reported to have difficult common bile duct cannulation, and 5.5% of the patients had cholangioscopy used in conjunction with the single-use duodenoscope. In terms of the flow breakdown, 160 of the 200 enrolled patients had ERCPs by the highly experienced endoscopist, while 40 had ERCPs by a less experienced endoscopist. And this differentiation was a little disappointing, but certainly had enough of a population to do comparisons statistically. If you look at the baseline characteristics of the 200 patients, the mean age was 63. Half of them were female, a little over half. And looking at the diagnosis or indications, abnormal imaging in 38%, bile duct stones in 32%, and biliary or pancreatic strictures in 27%. 2/3 of the patients had a prior ERCP, and about half the patients had a prior sphincterotomy. With regards to the ASGE grades, where 1 are relatively simple and 4 are more complex, we had a nice distribution of complexity: 10% grade 1, 48% grade 2, 30% grade 3, 11% grade 4. If you look at the comparisons of outcomes between the experienced and less experienced endoscopists, we saw no difference in being able to complete the ERCP, over 95% in both groups. The crossover rate was 11% with the highly experienced and only 2.5% in the less experienced that did not reach statistical significance. The overall satisfaction was identical within the two groups and was very favorable, with a rating of 8 out of 10 in both groups. Serious adverse events had an acceptable level of 7% with the experienced endoscopists and 5% in the less experienced. The procedural time was identical between the two at 25 and 28 minutes, respectively. The number of cannulation attempts was identical, and the ASGE complexity grade was similar between complexity 1 through 4 in the highly experienced and less experienced endoscopists. When you look at the comparison of the outcomes of both groups by the grade of complexity, again, ERCPs were completed when we lumped grade 1 and 2 together and compared that to grade 3 and 4. Over 95% in both groups. The crossover rate was similar between the easier and more complex procedures. The overall satisfaction was the same. The adverse events were the same. The only significant difference was in the procedural time, which was 19 minutes for the less complex and twice that at 39 minutes for the more complex procedures, and that was statistically significant. The mean number of cannulation attempts was similar in both groups. In terms of serious adverse events, very reasonable number for a prospective study at 6.5%. We saw 2.5% bleeding. We saw post-ERCP pancreatitis in 1.5%, cholangitis in 1%, and then a series of minor complaints in a single patient to round off the total numbers. So in conclusions, endoscopists with varying levels of procedural experience used the first marketed single-use duodenoscope to complete most consecutive ERCPs, including the most complex procedures. Crossover rates, cannulation attempts, user satisfaction were similar for highly experienced and less experienced endoscopists. So moving forward for our readers, it appears very reasonable to gain some familiarity with this scope to try and incorporate it into your practice. How we use it is an evolving strategy. Very exciting news was Medicare giving reimbursement through a pass-through code for outpatients and hopefully for inpatients later this summer or this fall. This should help strategize who to use it on and when to use it, and help control the added expense to your capital budget. People are designing and defining different strategies of how to incorporate these scopes into their practice. We currently are using it in highly vulnerable patients who require multiple ERCPs, and in patients who are known carriers of MDROs, but other factors such as hospital volume, et cetera, and what you're currently doing to fulfill FDA mandates for extra precautions that are required for duodenoscope use will obviously impact strategies at your hospital. So thank you very much for this opportunity.